Bismillahirrahmanirrahim. Assalamu alaikum and good evening. Coming back to our dentistry videos, today I have selected a special topic for discussion. It includes a morphological dental anomaly involving the internal anatomy of the tooth. This anomaly is very special and it poses serious challenges in the diagnostic procedures as well as in the clinical management of such cases or such teeth. Before we proceed to discuss this anomaly, I would like to show you a model of the tooth. As you can see this model, it has a crown portion and a root portion, and the root portion is multi-rooted. The anomaly affects the multi-rooted teeth involving the bifurcation or the trifurcation of the teeth. So you have to see the anatomy. This is the crown portion which is visible in the oral cavity, and this is the root portion and the cervical constriction which is embedded in the gums or the alveolar bone. So we will discuss this anomaly later on, and I would also like to show you a special cross section of the tooth showing the pulp chamber and the root canals with the pulp in these canals. So you should look at these and then we will discuss about the anomaly. The anomaly which is under discussion today is taurodontism. So what is taurodontism? Taurodontism is basically a developmental morphological anomaly involving the internal anatomy or the internal shape of the tooth. So it is very difficult to diagnose clinically or on external examination or the naked eye examination to see whether the tooth is taurodont or not. What are the features we can discuss? The salient features or the important features of taurodontism or the taurodont tooth are enlarged and rectangular type of pulp chambers and deepened furcation areas which results in the shortening of the roots. जैसे कि हम यहाँ देख सकते हैं, ये टूथ हमारे सामने है, ठीक है. इसमें ये क्राउन पोर्शन है, ये रूट पोर्शन है, ये सर्वाइकल कंस्ट्रिक्शन आ गई, ठीक है. अब जब जो चेंबर है हमारा वो यहाँ ज़्यादा क्लियर आप देख सकते हैं. दिस इज़ द पल्प चेंबर, रेडिश एरिया आप देख रहे हैं यहाँ तक, जहाँ बाइफर्केशन से ऊपर ऊपर ये पल्प चेंबर है, ठीक है. ऊपर इसकी रूफ है, नीचे इसका फ्लोर है. तो जब ये एरिया डिप एंड डाउन होना शुरू हो जाएगा और ये फर्केशन जो है शिफ्ट हो जाएगी टुवर्ड्स द एपिकल पोर्शन, दिस इज़ द एपेक्स ऑफ द रूट. तो जब ये एपिक्स की तरफ शिफ्ट होना स्टार्ट हो जाएगी, फर्केशन डीपेंड होना शुरू हो जाएगी, चेंबर बड़े होना स्टार्ट हो जाएंगे, तो एक ख़ास रेशियो के बाद हम इसको डायग्नोसिस में कहते हैं द टूथ इज़ टॉरोडोंट और द टॉरोडोंटिज्म इज़ प्रेजेंट इन दिस टूथ. तो ये एक जनरल समझने के लिए अभी हम आगे इसको मज़ीद देखेंगे किस तरीके से हम इसको कंफर्म डायग्नोस कर सकते हैं, इसकी क्या रेशियो हो सकती है, इसकी क्लासिफिकेशन. In the primitive times, this anomaly was known as cylindrical teeth or the prismatic teeth due to their shape of the pulp chambers. But in 1908, there was a scientist named Borjanovic Kramberger who first invented the word taurodontism in science. And then in 1913, Sir Arthur Keith was the first dentist, you can say, or the dental professional who used this word for the anomaly of these teeth and named this anomaly taurodontism. And this word basically it is derived from two Latin words. The first one is tauros, which means bull-like, and second one is odonto, which means tooth or teeth. So the word taurodontism is basically due to the bull-like shape of these large pulp chambers of these teeth. So the bull-like teeth or the bull tooth, this is known as taurodontism. The characteristic picture of the taurodonts or the taurodontism can be described as the teeth which are lacking the cervical constriction at the cemento-enamel junction with vertically enlarged pulp chambers and deepened furcation areas along with shortened roots. This is basically described in these four types of characteristics, and you can easily diagnose these on the radiographs or the cross sections of the teeth. The exact mechanism or the procedure for the formation of taurodont teeth is still unclear and unknown, but we can easily understand if we see the process of the formation of roots. You all know that basically the roots of the teeth, they form through the designated mesenchymal or epithelial cells, and the internal enamel epithelium, it gives rise to the Hertwig's epithelial root sheath, which basically gives the basic outline of the root formation. So in multi-rooted teeth, this Hertwig's epithelial root sheath, it needs to invaginate or start an invagination, which results in the formation of bifurcation or the trifurcation and the separate roots in the development process. But what occurs according to the hypothesis of Taurodont teeth, basically it results in the delayed or failure of the invagination of this Hertwig's epithelial root sheath, which can result in the formation of different types of developmental morphological anomalies. And one of these is taurodontism. Others can be accessory canals or accessory roots, they can occur, or cylindrical roots or dilacerated roots. These all can occur through this process. The second theory is the genetic mutation. They say that X-linked trait or autosomal dominant trait can be the reason for the formation of taurodontism or the taurodont teeth. So it can be due to genetic mutation, or it can due to developmental defect or the failure of the invagination or the delayed invagination of Hertwig's epithelial root sheath. When we discuss the prevalence of taurodontism, there is a wide range, and it ranges from 0.1% to 60%. And the most commonly involved areas are basically Central America, Alaska, Australia. Other areas can also be involved. When we see its predilection in genders, there is no clear predilection. It occurs in both genders equally. But in some studies, they say that women can be more affected with this anomaly, and all type of teeth can be affected, permanent as well as deciduous. But it is more common in the permanent teeth. And permanent mandibular molars are most commonly involved. Then comes the maxillary molars, and then the premolars. And it can occur in multiple teeth in a single individual, or it can be in isolated form. So this is the prevalence of this tooth. And when we see about the diagnosis, this is basically a chance radiograph finding. This is not clinically visible in the oral cavity. We will see further about the diagnosis in the next part of the video. Taurodontism was first of all diagnosed as a chance finding on the radiographs, and there was no specific index or anything to assess the severity of the taurodontic teeth. So, first of all, conventionally, uh, Keen established the taurodont index or the conventional taurodont index, which was used to radiographically assess the severity of taurodontism based on the quantitative radiographic assessment. In this method, they took a ratio. Basically, they divided the tooth in two calculations, and then they multiplied it with 100 and get the ratio. So we will discuss this like this. They took a ratio from the height of this roof of the chamber and the floor. This value was known as V1. Then they calculated from the height of the chamber to the longest apex or the apical area of the root, and this value was known as V2. When they divided V1 and V2 and multiplied it with 100, they got certain values depending upon the severity of the condition of taurodontism. So the values then classified the condition into four different types. The first one was cynodont or the normal tooth, and the value for V1 over V2 multiplied by 100 was 0.24% to 9%. And when the value goes up to 25% to 49.9%, all the teeth which lie in this ratio, they were termed as hyperdonts or the mild taurodontism. And when the ratio goes even higher and it became 50 to 74.9%, then they classified it as mesodonts or the moderate taurodontism. And when the value goes even higher from 75% to 100%, the teeth were termed as hyperdonts or the severe form of taurodontism. This was the conventional index. but it has many drawbacks and it does not take into account the different other aberrations and also gave any false ratios. So other scientists, which were Schiffman and Chanel, they decided to alter the index of Keene, and they included another value in the V1 and V2 value. They proposed a third value which was V3, and they calculated V3 as the ratio from the cemento enamel junction to the lowest point, you can say, or the inferior point of the pulp chamber, and they proposed that this value should be 2.5 millimeter or more. And this also shows that this value will be greater than the occlusal vertical dimension from the height of the chamber floor towards the occlusal aspect of the crown. And they said when the value is 2.5 millimeter or more, in addition to the 0.2% or the 20% which was given in the Keene index, or the 25% for the mild form or the hypo form of the disease, or the anomaly, then we can classify it as mild or the hypodont. So when they added the value V3 and this value which was taken from the cemento enamel junction to the lowest part of the pulp chamber, and it is 2.5, and the ratio of V1 over V2 it is greater than 0.2 or 20%, then the tooth is taurodont. And according to this classification, the cynodonts are classified as less than 20% of V1 over V2 ratio when the V3 is 2.5, and the mild or the hypoform it will be 20% to 29.9% provided that the V3 is 2.5 millimeter or more, and then the moderate or the mesoform it is 30 to 39.9% provided that the V3 is 2.5 mm or more, and the severe form is 40% to 75% of V1 over V2 when the V3 is 2.5 millimeter or more. So the Schiffman and Canal alternate method, or the modified taurodont index, it classified the teeth into cynodont, then hypodont, mesodont, and taurodont and hyperdont, and the value was quite clear, as they said for cynodont it should be less than 20% V1 over V2. For hypodonts it should be between 20% to 29.9%, and for mesodont it should be 30 to 39.9%, and for hyperdont, or the severe disease of form of taurodontism, it should be 40% to 75%. And there were also modifications by other scientists like Shaw, but these were erroneous and they were not taken into account. All these methods, these classified taurodontism, and these were quite helpful for the diagnosis and for the assessment of the severity in a quantitative manner. But still there were certain limitations for the classification of taurodontism due to certain facts, which are: there were variation in root length between genders and ethnic groups. Different genders, different ethnic groups have different ratios, and it can affect the severity index. And then there was a change in root length due to resorption. Resorption can occur due to different conditions like atresion, tooth wear, or bruxism, or any other anomaly like aminogenesis imperfecta or any other thing. So these can also affect the quantitative severity index or the quantitative assessment of the severity of taurodontism in not in a very good way. Then the third one was the short roots due to immature root development. The root development can be immature, and it can also affect the quantitative assessment of the taurodontism. Nowadays, internal anatomy characteristics or the features are used to diagnose or assess the taurodontism. So these can be assessed through clinical findings or the internal morphology and radiographic features. When we see the clinical findings, Basically, it is done through the periodontal probing of the multi-rooted teeth. You can see here, we have already discussed that in taurodontism, the apical displacement of the furcation area it occurs. So when the furcation area is apically displaced or the furcation is deepened, when we put a periodontal probe in the sulcus, normally it gets stuck like this in the furcation area. But in taurodont teeth, it will get stuck against the hard surface as the furcation area has already deepened down or it is apically displaced towards the apex area. So this finding will confirm or it will make us suspect that there may be a taurodont or the taurodontic tooth in uh, account. So now after this assessment, we will see the internal morphology characteristics through the radiographic assessment. So we have already discussed in the radiograph, we will see a deepened furcation area, short roots, large cylindrical pulp chambers, cylindrical and rectangular shaped teeth, vertically enlarged pulp cavity extending below the cemento-enamel junction, high roof of the pulp cavity, elongated body of the tooth or the tall root trunk can be seen. Other one will be the absent or the underdeveloped cervical constriction at the cemento-enamel junction. This is very important. The cervical constriction will be flattened. There will be no cervical constriction and it can also be judged very easily. And next one is the apical displacement of furcation. We have already discussed this, and the thin cervical dentine at or around the canal orifices. The dentine thickness will also be less, and these features will pose a challenge for the endodontic treatment or the root canal treatment in future. Small to absent interradical area can be present, and the short roots and short root canals are present. So when the chamber becomes elongated, cylindrical, rectangular and increased in size, it will also hamper a successful excess cavity preparation. All these endodontic challenges will be discussed later on. Regarding the differential diagnosis of taurodontism from certain other developmental anomalies, amelogenesis imperfecta and dentinogenesis imperfecta come at the top of the list. And certain types of amelogenesis imperfecta, they are also associated with taurodontism. And when you see orthopentomograph or the OPGs of many patients with amelogenesis imperfecta, you can also see taurodontic teeth along with this condition. Otherwise, in all other conditions, when you diagnose taurodontism or taurodontic teeth, the external surface or the features of the teeth are absolutely normal except in amelogenesis imperfecta or dentinogenesis imperfecta. However, you can differentiate AI and DI from taurodonts through certain points, which are AI and DI may have incomplete developed roots and open apices, while hyperdonts or taurodonts or taurodontism does not contain these features. Other diseases which come in the differential diagnosis are hypophosphatasia, rickets, and pseudo hypoparathyroidism, and these can also be differentiated through wide pulp cavities in these conditions. So this is the small differential diagnosis of taurodontism or the taurodontic teeth. When we see the association of taurodontism or the taurodontic teeth with certain syndromes, there come many names. So these can also be these can also be taken into account when you see such patients with such syndromes, that there can be taurodontic teeth or taurodontism present in this condition. Certain names are given here, like the association is most frequently seen in cleft lip and palate patients, hypodontia, oligodontia, amelogenesis imperfecta, Down syndrome, Klinefelter syndrome, Mohr syndrome, Williams syndrome, trichodonto-osseous syndrome, thalassemia major, and McCune-Albright syndrome. These are certain names of the syndromes which can be associated with taurodontism or the taurodontic teeth. Now there comes a question whether conventional radiography should be used for the assessment or diagnosis of taurodontism, or cone beam CT scans can be used or should be used. So different clinicians or experts, they advise that in case of hyperdonts with severe form of taurodontism, it is advised that CBCT scans should be used before doing the root canal treatments or any other clinical procedures in such teeth. So different features or different conditions we should be taken into account before the final decision for the CBCT scans. These can be the presence of thickness of pulpal floor adjacent to root canal orifices, and the number of root canals and the canal curvatures, especially the buccolingual direction. These are the features which should be taken into account, and it is recommended that in hyperdonts, before doing the root canal treatment, you should expose a CBCT scan for prevention of any complication or any procedural error in the process. So the clinical management of taurodonts, especially hypertaurodonts, is a very special case, but we will discuss this in detail in the second part of this video. So stay tuned. If you like this part of the video, like and share it, and do not forget to subscribe our channel so that you can get notifications for our future videos based on the dental education topics as well as the oral health awareness for general public. Thank you very much.